Hello, students. Welcome to this episode of Theory Lecture in Obstetrics. Today, we'll be talking about hyperemesis gravidarum. So, what do you mean by hyperemesis gravidarum? Okay. So, this is a topic which is a small topic, but questions generally come from this hyperemesis gravidarum. So, I want you all to listen to me for this lecture today. Okay. So, by hyperemesis, what we mean is hyper means excess. Hyper means excess. Okay. And emesis means vomiting. Okay. So, emesis means vomiting and gravidarum means pregnancy. Okay. So, whenever you have excessive vomiting in pregnancy, then it is called hyperemesis gravidarum. So, what do you mean by hyperemesis gravidarum? When do you say there is hyperemesis? Remember, some degree of nausea and vomiting is very common in pregnancy. People in pregnancy have nausea and vomiting. How many percentage of patients have nausea and vomiting in pregnancy? Almost 50 to 80% of women have nausea and vomiting in pregnancy. But out of them, only less than 5% of the women will land up in hyperemesis gravidarum, means excessive vomiting will be less than 5%. But always remember that this is a very recurring phenomena. It is recurrent. It means if patient has hyperemesis gravidarum in one pregnancy, then next pregnancy the recurrence rate of hyperemesis gravidarum is 81%. Next pregnancy there is 81% chance that the patient will land up in having hyperemesis gravidarum. Hyperemesis gravidarum is very common in the first trimester of pregnancy. This means the symptoms start from 4 to 7 weeks of pregnancy and it peaks at around 9 weeks, and then it keeps on falling till 16 weeks, and by 20 weeks all the symptoms are over. So by the second trimester, the starting of the second trimester, then all the symptoms will be over. So 20th week tak most of the women will have their hyperemesis resolved or any emesis resolved. So when do you say a patient is having hyperemesis? Hyper kab bolenge? Hyperemesis gravidarum when the triad is fulfilled, when three things are fulfilled. So what are the three things in the triad? Number 1, protracted nausea and vomiting. Protracted nausea and vomiting means बहुत severe nausea and vomiting, just like patient का esophagus tear हो जाएगा. Protracted nausea and vomiting. Number 2 is patient should have dehydration and electrolyte imbalance. So dehydration and electrolyte imbalance होना चाहिए. And number 3, when there is weight loss. How much of weight loss? Weight loss more than 5% of pre-pregnancy weight. 5% of प्री-प्रेगनेंसी वेट, इतना वेट लॉस होना चाहिए, तब बोलेंगे सिग्निफिकेंट वेट लॉस है इन प्रेगनेंसी बिकॉज ऑफ नॉजिया एंड वॉमिटिंग. So very clear, hyperemesis gravidarum has a triad. All the three has to be fulfilled. One is protracted nausea and vomiting, second is dehydration and electrolyte imbalance, and third is weight loss more than 5% of pre-pregnancy body weight. So the main culprit for hyperemesis gravidarum is the HCG hormone, human chorionic gonadotrophin hormone, and higher estriol levels in pregnancy. Estriol, we all know, E3 increases in pregnancy from your placenta. It is secreted from the placenta. So HCG and estrogen levels, when they are increased, then this leads to hyperemesis. Similarly, if patient is having hyperthyroidism, then your thyroxine hormone is increased. Okay, so thyroxine hormone T3, free T3, which is the active form of thyroid hormone, if that increases, that also is a culprit for hyperemesis gravidarum. So once a patient is having hyperemesis gravidarum and has come to you, you have to evaluate the patient. You have to see. So history, patient will be telling lot of nausea and vomiting. She will not be able to tolerate any food. Liquid लेते ही उसको vomiting हो जाता है. So this is the thing which is saying. Then apart from history, you have to do an examination. You have to look for signs of dehydration. So sunken eyeballs and your tongue is dry. So these all things will be found. Apart from that, there can be muscle wasting, protein energy malnutrition will be there, patient will have muscle wasting. Then abdominal examination has to be done to look for FGR. Patient can have FGR if it is in third trimester, or in the first trimester patient can have a scaphoid abdomen. So these are all the your findings which can be there. Then what you do is always do a bedside dipstick examination. Bedside urine dipstick examination. In urine dipstick examination, you try to look for urine ketones. Ketones is something we check. Although latest RCOG guideline says that ketonuria is no longer considered for diagnosis of hyperemesis gravidarum, but we generally tend to do urine ketones. If ketones are large, moderate to large amount of ketones in urine, then you say that it is ketonuric and patient will need a lot of IV fluids because ketone bodies are forming because patient is dehydrated and patient is not able to take any fluid. Okay, apart from that, in investigations we get a CBC done to look for any infections, any pyelonephritis or something which can be secondary causes of hyperemesis gravidarum. So TLC count will be increased in infections, secondary infections. Do a blood sugar monitoring, glucose monitoring is done to look for, rule out any diabetes because diabetic ketoacidosis can also lead to hyperemesis gravidarum. Urea and serum electrolyte levels are measured to look for, because during vomiting you have your sodium and potassium levels go down, so it is actually hyponatremic hypokalemic metabolic acidosis which occurs. So get an ABG done. Arterial blood gas analysis can also be done, which tells you about metabolic acidosis, that is the pH level can go down, metabolic acidosis can be found. Apart from that, you can do an ultrasound scan to look for what is the status of the baby, whether viability has attained or not, fetal heart rate is normal or not. So these are the investigations which are done. Once you have done the investigations and you know patient is having hyperemesis gravidarum, then you quantify the hyperemesis, that is there is a scoring system. This is very very important because MCQs always tend to come from this scoring system in NEET PG or even in INI-CET. Puke scoring is pregnancy unique, quantification of emesis, okay. So in this, what scoring do? You generally do a scoring whereby you have 3 questions to ask. Number 1, how many hours did you have nausea in the last 24 hours? In the last 1 day, how many hours did you have nausea? How many hours did you feel nauseated? If the answer is 0, patient had no nausea, then score given is 1. If it is less than equal 1 hour of nausea, then score given is 2. If it is 2 to 3 hours, then score is 3. 4 to 6 hours, then it is score given is 4. And more than equal 7 hours of nausea, score given is 5. The second question which is asked is, how many times did you have vomiting in last 1 day? How many times did you vomit? Okay, so if the answer is no vomiting, then score is 1. If it is 1 to 2 times, then score is 2. 3 to 4 times vomiting, score is 3. 5 to 6 times vomiting, score is 4. And more than 6 times vomiting, then it is, the score is 5. Okay, 7 or more times vomiting is 5. Then the third question is, how many times did you have retching? Retching means you were feeling like your esophagus will get torn with vomiting. So if there is no, then it is score 1. If it is 1 to 2, then score is 2. Just like vomiting, how many times vomiting? Similarly, how many times retching? 5 to 6 times, then score is 4. And more than 6 times retching or more than equal 7 times, score is 5. So the minimum score you can see can be 3 and maximum score can be 15. 5 plus 5 plus 5. Okay, so the score range is from 3 to 15. Similarly, you will divide it into mild, moderate and severe type of hyperemesis. Okay, mild hyperemesis is when the score is less than equal 6. When the score is 7 to 12, it is moderate emesis, hyperemesis, and 13 to 15 score is severe hyperemesis. In mild hyperemesis, we give an OPD treatment, outpatient basis. So दवाई देके पेशेंट को भेज देते हैं, OPD basis पे ही treatment होता है. Severe form में you have to do an IPD treatment, that is inpatient. You have to admit the patient and give IV treatment. But in moderate hyperemesis, you go for ambulatory daycare management. Very very important. इसमें question आता है ambulatory daycare management. What do you mean by ambulatory daycare management? Ambulatory daycare management का मतलब है कि you admit the patient for few hours, okay, in the ward, give some IV fluids, and then by the evening, by the time the OPD finishes, you discharge the patient. Overnight, you will not keep the patient in the hospital. So this is ambulatory daycare management. अब क्वेश्चन आता है कि हम मैनेज कैसे करते हैं. व्हाट आर द ड्रग्स दैट यू गिव इन हाइपरेमेसिस इन प्रेगनेंसी, बिकॉज यू कैन नॉट गिव ऑल ड्रग्स इन प्रेगनेंसी बिकॉज दे कैन बी फीटोटॉक्सिक. So the first line of management, first line drug which is given is always antihistaminics. Antihistaminic drugs are the first line of management in pregnancy. Antihistaminics, the H1 antagonists, are actually the first line management. So H1 antagonists, what are the drugs which are first line? Number one, you can give cyclizine. Cyclizine is the drug which is most preferred, 50 milligram per oral once daily, or if patient is in ambulatory daycare, then IV or IM can be given. Second is your prochloroperazine. Prochloroperazine is the drug which is given. Prochloroperazine का dose होता है 5 to 10 milligram per oral, or IM or IV can be given once a day. Or the third first line agent can be your promethazine. Okay, so promethazine dose is 25 milligram tablet आता है per oral, IM or IV injections can be given. Cyclizine, prochloroperazine and promethazine are the first line drugs which are given. If these antihistaminics do not work, apart from antihistaminics, you also give folic acid and doxynate to the patients. Okay, so folic acid is vitamin B9 which also helps in preventing vomiting, and then your doxynate, or the drug name is doxylamine is given. Doxylamine or doxynate drug is given. It is 10 milligram tablet is available. It can be started from once daily, that is 1 tablet BD, and it can be given up to 2 tablets TDS. So maximum dose can be 6 tablets in a day can also be given. These are the first line drugs and no side effects. The second line drugs which are given if first line does not work is number 1, your metoclopramide. Metoclopramide and domperidone. These are the drugs which are having anti-emetic effect because they increase the gastric motility. So gastric motility is being increased, so gastric emptying is increased, so less and less of reverse peristalsis and less of vomiting. Metoclopramide dose is 5 to 10 mg and it is given every 8 hourly. Okay, TDS it is given. Domperidone dosage is 10 milligram tablet आता है and वो भी 8 hourly दिया जाता है. Very very important, the question that comes is metoclopramide का क्या side effect है. So always remember metoclopramide is associated with extra pyramidal symptoms. Very very common and इस पे questions आया है many time. Extra pyramidal symptoms are common with metoclopramide drug. That is why it is not the first line drug in pregnancy. Apart from that, the third second line drug is ondansetron. Ondansetron is very powerful antiemetic. Okay, it is given in a dose of around 8 milligram tablet आता है and you give it 8 hourly. Okay, 8 hourly. Sometimes 4 milligram tablets are also available in the market. If it is not controlled and patient is having a lot of vomiting, then the third line management which is given is give corticosteroids are steroid drugs which will prevent vomiting. So the corticosteroid which is of preference is hydrocortisone, because hydrocortisone is a very short acting corticosteroids. Hydrocortisone is given in a dose of 100 milligrams IV or IM, because patient is, by that time patient is admitted and severe hyperemesis हो जाता है, तो हाइड्रोकॉर्टिसोन देते हैं 100 milligram IV BD twice a day. Okay, twice a day you give until the vomiting stops. Once the vomiting has stopped, then you turn over to long acting steroids in the form of prednisolone. Prednisolone can be started, and prednisolone dose will be around 50 milligram IV, or you can give per oral also, and then slowly try to taper the drug, because steroids you have to taper, otherwise patient will become addicted to steroids. Okay, so the lowest maintenance dose is given and then slowly it is stopped. So this is how we really manage patients of hyperemesis gravidarum. Apart from that, always remember IV fluids have to be given, because patient will be kept NPO, मुंह से कुछ नहीं देना है, because they are not able to tolerate foods. So try to give IV fluids always. So IV fluid, the fluid of choice, very important, is ringer lactate. RL is the treatment of choice, ringer lactate. Why? This is because it is similar to physiological plasma की तरह होता है ringer lactate in composition. So the best fluid is ringer lactate. But the next question comes, if ringer lactate is not available or not present in your MCQ option, then the next best will be normal saline with potassium chloride. How much of potassium chloride is added? Potassium chloride you generally try to add 40 millimoles per liter. 40 millimoles per liter is added to 1 vac of sodium chloride. This is because I have already told it is hyponatremic and hypokalemic metabolic acidosis. So you have to replenish with sodium as well as potassium. Always remember, the IV fluid which is never given is dextrose. Dextrose or DNS is never given to patients of hyperemesis gravidarum. Sugar containing fluids is not to be given. Why? Now this is a very pet question. This is important question. So this always comes in examination. Why dextrose is not given? This is because, remember the thing that when dextrose goes inside the cell, if this is a cell and sugar is going inside the cell with GLUT transporters, you all know GLUT transporters, GLUT2, GLUT4 helps in glucose transportation inside the cell. So GLUT transporters utilize potassium. At the same time, when GLUT is going, then potassium also goes inside the cell. And number 2, your vitamin B1 is thiamine also goes inside the cell. So glucose जब अंदर जा रहा है तो thiamine को भी intracellular ले जाता है, तो your extracellular or plasma concentration of vitamin B1 decreases. There is vitamin B deficiency, and B1 deficiency leads to a very dreaded complication which is called Wernicke's encephalopathy. Okay, so Wernicke's encephalopathy can be precipitated if patient is given dextrose solution when patient is having hyperemesis gravidarum. So what actually happens is in Wernicke's encephalopathy, you can remember with the mnemonic I have made GOA, GOA. So G stands for gait abnormality. So patient will not be able to walk properly. Patient will fall down every time. O stands for ophthalmoplegia. It means patient will have difficulty in vision. Patient will have blurring of vision. And A stands for amnesia. Patient will not remember anything. So overall, patient will not be able to walk, patient will not be able to see properly, patient will forget everything. So patient will have the symptoms of poor GCS, that is poor Glasgow Coma Scale. So patient will thereby धीरे धीरे डिटोरिएट हो जाएगा, पेशेंट्स का कंडीशन will be very poor. So the only thing is that you have to, if patient is having such type of symptoms, that patient is not able to remember, not able to recall anything, and Glasgow coma scale is going poor, then what you will do is you give thiamine infusion to these patients. Thiamine infusion has to be given immediately, because this is because of Wernicke's encephalopathy. Very, very important, and questions really come. Never forget this thing after today. Okay, so Wernicke's encephalopathy has to be treated. So this is actually the management which is done. IV fluids are replenished more and more. Patient is hydrated. Always go for input output charting. How much is the output? Calculate that, and 500 ml more will be your input, because there is some loss from the skin also during perspiration. So this you have to maintain. And apart from that, always remember, try to rule out the secondary causes of hyperemesis. Secondary causes are like, if you start from head to toe, patient can have migraine. A patient of migraine during pregnancy will have hyperemesis. Then patient can have your preeclampsia. Always try to take the BP and rule out preeclampsia, because preeclampsia can be a cause of blurring of vision, and then patient can have HELLP syndrome, and patient can have these all symptoms. Then patient can have gastritis. There can be H. pylori infection and gastritis, which can be risk factors for hyperemesis gravidarum. Then you can have your gynae conditions like degenerated fibroids. Degenerated fibroids or red degeneration in pregnancy is also associated with pain abdomen and nausea and vomiting. Then there can be torsion of any ovarian cyst. Torsion of ovarian cyst. So the most common cyst which torts is your dermoid cyst or mature cystic teratoma, because they are very light and they try to float in the abdomen and they undergo torsion. So this can be a cause of need for surgery can also be there. Apart from that, renal colic, patients of kidney stones will also land up in having nausea and vomiting in pregnancy. Then pyelonephritis. So that is why infections in pregnancy, okay, UTI, they can be cause of nausea and vomiting and hyperemesis. So always do TLC count, urine routine, urine culture has to be done to rule out these secondary causes. Apart from that, your diabetes mellitus, type 2 diabetes mellitus is associated with gastropathy, and it can lead to your nausea and vomiting in pregnancy. Apart from that, hyperthyroidism, I have already told, can be one of the causes. Addison's disease, okay, and your phenylketonuria, then your porphyria. Okay, so these are some of the metabolic syndromes also which can lead to hyperemesis. So always try to rule out these. Apart from that, also remember sometimes that female fetus is also associated with more of nausea and vomiting in pregnancy, because female fetus adds to the estrogen in the blood. So estrogen content goes high and patient can have nausea and vomiting in pregnancy. Other risk factors which you always try to rule out is patient of low BMI. You will find most of the patients who are very thin built and very low BMI, they have nausea and vomiting in pregnancy. Family history, I have already told. H. pylori infection, low BMI, and your the patients who have had like family history, those whose sister was having hyperemesis gravidarum, they also have hyperemesis gravidarum. So your treatment will be such that you make the patient NPO, try to replenish the IV fluids, and then slowly you start the patient with oral diet. When you start oral diet, always remember, start with soft or dry fruits. Okay, dry fruits are started, followed by liquid. Liquid is not started initially, because liquid से generally hyperemesis होता है. So liquids are started later. First give dry fruits or soft food, biscuits, toasts are given, and IV fluids are given. Then slowly you start with oral fluids. So very important. This is a short topic. Always remember, Wernicke's encephalopathy comes as a question, an MCQ question. How will you manage? Fluid management is very important. First, second and third line drugs are important, and your puke scoring. Puke scoring always comes in question. Okay, puke scoring was given by RCOG, Royal College of Obstetricians and Gynecologists, that is UK guideline. So all the best. I hope you have understood. Any questions you have, try to put in the chat box so that I can answer all your queries, and let me know what other topics you want to study so that we can plan out our sessions accordingly. Thank you so much for your patience hearing.